Okay. So it's a pleasure to introduce Dr. Pete Lawrence. Pete, we've known Pete for a long time. He started working with us in Oxford in 2010 and spent 4 years with us working on our Oxford postnatal depression treatment trial. And he quite honestly was a most fantastic and inspirational and charismatic therapist and a wonderful person to work with. And we've missed him. But we've kept in touch ever since, and he's moved to good hands, as it were, and he went to become a lecturer in clinical psychology at the University of Southampton. And then in the middle of it all, got a fellowship to do his PhD with Kathy Cresswell, which is good. And the subject of his PhD is the subject of his talk today. And he's then gone back to University of Southampton as a lecturer in clinical psychology. So he's going to talk to us about anxiety disorders, risk and prevention. Pete, it's all yours.
Thank you very much, Alan. Pleasure to be remotely with you all. Obviously not housekeeping, but I should explain I'm sat outside a university building in order that I have better Wi-Fi access than at home. So forgive possible interruptions because I'm essentially in a public place. So I should also say thank you to very many people. Many students who've helped me with all the work I'm going to tell you about, academics who've helped me and have contributed as authors to the studies, the families who've participated, and the funders of the work. Thank you also to these key people. You'll recognise many of these faces, I'm sure. Professor Kathy Cresswell, who's been my primary supervisor for my PhD. Professors Lynn Murray and Peter Cooper, whom many of you will know, with whom I worked on the postnatal treatment trial Alan mentioned. Paul Ramchandani, who's over in Cambridge now, but with whom I nearly got to do a PhD, examining postnatal depression in fathers and infants' development. And centrally there, under the umbrella, Alan himself. What you'll notice, that umbrella is supposed to capture people who work examining children's development in the context of risk. And that's exactly what I'm going to be telling you about today. What I'm going to try to do is to give you the background to all the studies I'm going to tell you about. So I'm going to tell you about 4 studies that I conducted for my PhD. I'm going to try to give you all that background to begin with, and then give you the highlights from each study, rather than going through each one completely systematically and methodically due to time limitations. So please forgive me if I speak as quickly as Steve Holland and give 2 talks in the space of time for one. So, anxiety disorders. Well, worldwide, we know that actually they're the most common mental health problem in children and young people. I think the point estimate's just about 6.5%. So the most common type of mental disorder in children and young people worldwide. They have a very early age of onset. 50% of them will have begun by the age of 11 years. And we know that they're very serious because not only are they themselves a psychiatric disorder, they're chronic, so they tend to go on. Some just don't tend to disappear by themselves without treatment. They interfere in life more broadly as well, socially, in terms of children and adolescents' education and family. We know that they can have long-standing impacts. And what you might notice at the bottom of the slide here is that there are different subtypes of anxiety disorder. So it's a whole class of disorders. And presently it comprises these 6 that you'll see here: agoraphobia, generalized anxiety disorder, panic disorder, separation anxiety disorder, social anxiety disorder, and specific phobia. And the reason I'm letting you know about that is so I can sort of zoom you in on social anxiety disorder in particular. This is one of the most common anxiety disorders. And it's characterized by this recurrent, intense anxious response to being in a social situation or anticipating going into one, where you expect to be under the scrutiny or evaluation of your peers. And that's really important, that it's peers. So for children, it has to be, they expect that scrutiny from others their own age, and for adults, from adults. Again, its most common age of onset is in childhood and early adolescence, median onset under 13 years. Typically, it's chronic. It goes on for many years if left untreated, and it's associated prospectively, so it predicts later adverse educational, psychiatric, and social outcomes. So it's a real problem. In terms of treatment for anxiety disorders, so the first line of treatment is cognitive behavioural therapy. You'll probably have heard of this, CBT. But the thing is, although you can do a very good job, CBT is actually ineffective for over 40% of children and young people who manage to obtain and have a course of CBT for their anxiety disorder. Now, this is even worse in the case of social anxiety disorder. So in a large trial in the States, where children had social anxiety disorder, so the one I just highlighted for you, CBT led to remission rates of only 40% compared to 72% where children had anxiety disorders which were not social anxiety disorder. So we can see that although we've got treatments that are fairly good, they're actually ineffective for many, and then in particular for social anxiety disorder. There's also the issue of barriers to access to treatment. So this isn't a typo, but Tessa Reardon, one of your colleagues there in Oxford, recently published a paper showing that in the UK, of children with an anxiety disorder, in her study, less than 3% of those with an anxiety disorder were able to gain access to an evidence-based intervention. So that's less than 3%. So we've got treatment ineffective for many, but also when only a very, very, very small percentage are actually managing to gain access to treatment. So given these problems with treatment, given the problems of the disorder, given the barriers to access, naturally one might think about prevention. So not only have we got the concept of an ounce of prevention being worth a pound of cure, but it might also be the case that it's just easier to prevent anxiety disorders before they become established than it is to treat them, precisely because it might be easier to modify, to bring about changes in key developmental factors before the onset of the disorder than once they become crystallized during maintenance of the disorder. Now, there are different types of prevention. You can see here we've got universal prevention, indicated prevention, selective prevention. So universal prevention is where a prevention program is offered to all, regardless of whether they're likely or not to benefit because they're at risk or they're already experiencing problems. It's open to all. And now the thing is, for anxiety disorders, there's evidence that where you use a universal prevention approach, it's actually ineffective for those who might need it most. So Paul Stallard reported in his a randomized trial that he led in schools. You can see, I've circled for you in the top left, children who were high in anxiety to begin with, regardless of whether they had the CBT package led by a health professional or by a school professional or just the usual school provision. There was no difference between these groups at outcome. So the children who are high in anxiety, no benefit of this compared to usual school provision. Whereas those who were low in anxiety to begin with, they did show a benefit where those who received the CBT did significantly better than those who received CBT led by a school professional or just usual school provision. So it's actually the case that universal prevention is perhaps helping those who are not the ones whom we really want to help, those who are at risk. So rather than thinking about universal prevention, we might want to think about targeted anxiety prevention. And that means those two levels of indicated and selective prevention. So indicated programs are for those who are at risk of developing an anxiety disorder, and selective programs might somewhat overlap those who are already symptomatic, showing signs or experiencing symptoms. So what we really want to do is to be able to identify those who are at risk of anxiety disorders, who are the ones who are most likely to benefit from the prevention programs. Now this schematic from a theoretical paper, well, over a decade ago now, shows some of the key risk factors. And you'll see I've titled it Risk Factors and Targets for Prevention, because what we might think of is that where we can identify the risk factors for the development of anxiety disorders, you can see I've circled a few in red here. We've got parental anxiety, childhood constitutional factors, parental behaviours such as over-involvement or being less encouraging, and anxiogenic modelling, so behaving in an anxious way that your child observes and therefore thinks, well, behaving in an anxious way such as avoiding a situation or escaping from an anxiety-provoking situation, is how to deal with those situations. These risk factors might also be suitable targets for prevention. And a lot of what I'm going to tell you about today is working on exactly this issue. So not only have we got these risk factors from this theoretical model, also we've got what we don't know from the literature is whether risk factors operate additively or whether they interact. So is it that having one risk factor is only half as bad, as it were, as having two? Or is it that having two risk factors is many more times worse than one add one? I think I've explained that clearly. But this is really helpfully exemplified in a study conducted by Ashford over a decade ago, where children were assessed for not anxiety disorders, but internalizing problems at 2 years of age, followed up over the next 9 years. And those who had shown no risk factors when they were 2 years of age, their percentage risk for internalizing problems at age 11 was only 6.4%. Where they'd had one risk factor, you'll see the risk was 15.5. Where they had more than one, so that's only 2, 3, or 4, the risk shoots up to 48% of having an internalizing problem. So it does seem to be that actually it might be that it's not a simple additive relationship, it's that it's maybe cumulative. I don't know which way you can see me, but you're thinking about exponential growth with multiple risk factors. So the first two studies are going to be focusing on risk factors for the development of anxiety disorders. So we've got number one, risk of anxiety disorders in the offspring of parents with anxiety disorders. And then the second study about risks in infancy for the development of social anxiety disorder in childhood. And then studies 3 and 4 focusing more on prevention itself. So we're going to be asking, well, does targeted prevention of anxiety disorders actually work? Is it effective? And then finally thinking about the barriers to access to targeted prevention programs. So this is a little schematic showing the 4 steps in my PhD, as it were. So the first one, risks from parent anxiety disorders. Second study, risks in infancy for childhood social anxiety. Third study, is targeted anxiety prevention effective? And then finally, what are the barriers to access to targeted prevention? So this first study, just orienting you hopefully, parental anxiety. What are the risks associated with parental anxiety disorder for child anxiety disorder? So it's those 2 red circle ellipses that we're thinking about in this study. So what we knew already is very much that anxiety disorders aggregate in families. And we know this, these relationships run in various directions. If a child has an anxiety disorder, their parents are more likely to have an anxiety disorder than if their child doesn't have an anxiety disorder. And similarly, if a parent has an anxiety disorder, their child is more likely to have an anxiety disorder than if their parent doesn't. And it appeared initially from earlier work in the late 80s that the odds in offspring of parents with anxiety disorders were approximately 7 times greater themselves of developing an anxiety disorder. And also from an earlier meta-analysis, there'd been one previous meta-analysis, that there was an increased risk of all those different subtypes. So remember I showed you those 6 subtypes of anxiety disorder. It seems that where parents had anxiety disorders, their offspring were at risk of all of those. But some of the studies along the way, some longitudinal studies, that showed that actually parent anxiety disorders were not associated with any increased risk of offspring anxiety disorders. So we wanted to really pick apart those issues. And here I'm just trying to show you, with only 4 of the disorders, that anxiety is this class of disorders and they're separable, but they're overlapping. So you can isolate them, and in some cases people will have social anxiety without generalized anxiety or without panic or without specific phobia, but very often they co-occur. So what we didn't know before this study was about whether the subtypes of anxiety disorders in parents pose different risks to offspring of anxiety disorders. So you'll see in the, the left of the 3 top boxes, we're comparing parents with generalized anxiety to parents without. In the middle one, parents with panic disorder to parents without. and so on for social anxiety in the third box. And we're wanting to know, do the different anxiety disorders in parents pose different risks to their offspring? Also, what was unknown is whether a particular subtype of anxiety disorder in a parent, so for example, social anxiety disorder, meant their offspring were more likely to develop that same anxiety disorder, social anxiety disorder, or any of the other anxiety disorders, but not social anxiety disorder. So this simply hadn't been examined. So I'm going to have to skip through the methods, I'm afraid, in the interests of speed, but all was done to a high standard, pre-registered on Prospero, very thorough literature searches, all data abstracts and papers double screened and data double extracted, quality assessed, analyses in R, strongly recommend learning R, assessed bias with funnel plots and Egger tests and using Vivier and Wood's weighter function in R. So in summary, going from the initial literature search, we found 6,931 papers, narrowed it down to 25 papers, which actually come from, 25 individual cohorts across 53 papers. But this is an independent effects meta-analysis. So every cohort is providing only one outcome. So it's down to 25 papers. So in terms of what we found, well, compared to those original 7 times odds, what we found was that the relative risk is only 76% higher. Where your parent has an anxiety disorder, you're 1.76 times the risk of having an anxiety disorder compared to if your parent doesn't. So certainly a significant risk, but much smaller than those initial estimates. Where Miko had found in their meta-analysis that parent anxiety disorder posed the risk of all different types of anxiety disorders in offspring, we found that actually offspring were at increased risk only for generalized anxiety disorder, separation anxiety disorder, and specific phobia, but very curiously, not social anxiety disorder or panic disorder. Now this becomes quite complex and probably too detailed to get into today, but I will be touching on it. And then in terms of the novel questions we asked, so do the different subtypes in parents pose different risks for offspring? Well, if you look across the bottom from left to right, you'll see that generalized anxiety in parents was associated with an increased risk, 2.54 risk ratio. Parent panic disorder, smaller risk, 1.82. Parent social anxiety disorder, whilst it has a large effect size, 3.5 nearly, you'll see that confidence interval is huge and crosses 1. So it's not a significant risk. And that's really because it was from only 2 or 3 studies. So then the very interesting question, do the subtypes of disorder in parents pose a risk for the same disorder in offspring or different disorders? Well, there were enough data to examine this only for 3 subtypes, panic in parents, GAD, and social. And where we had adequate studies to say no for panic and no for GAD, you'll see those risk ratios well under 1 and the confidence intervals don't get near 1. For social anxiety disorder, again, we couldn't be confident. So maybe there is something different about social anxiety disorder, that maybe in parents it does pose a particular risk to offspring of social anxiety disorder rather than others. So what we can conclude, well, certainly there is this increased risk of anxiety disorders in offspring where parents have an anxiety disorder. There is that increased risk of the specific disorders, but there's a very complex issue regarding the specificity of risks of the different subtypes of anxiety disorders. And something I think that, well, I'd certainly love to do, but hopefully somebody's already doing it somewhere, is to try to bring together the data at the individual level, because to answer these questions, group level data simply don't allow us the granularity of detail to understand the particular risks. All that information is available, open access in that paper there at the beginning of last year, available online in open access. So learning from study 1, the risks from parent AD subtypes, but not necessarily for the same subtype. Study 2, so the risks in infancy for social anxiety disorder in childhood. So here, just to reorient you, we're going to be looking at various risk factors. So parental anxiety, parental modeling behaviors, parental parenting behaviors of over-involvement and encouragement, and behavioral inhibition in children, all as risk factors for child anxiety. So what we knew, well, we knew we wanted to be able to prevent social anxiety disorder, and that there were 3 broad risk factors. First, inhibited temperament. So that fits in there in the schematic. Well, this is the early temperamental style of increased reactivity to, or a tendency to withdraw from, novelty. It tends to be quite stable during development, so from early infancy through toddlerhood and on later into childhood. And in very early infancy, we call it reactivity. And from about the end of the first year, we call it behavioral inhibition. And having a reactive temperament in early infancy increases the chance of behavioral inhibition from the end of the first year. So a little schematic here, you'll see, you can imagine you're moving from left to right through time. Reactivity is associated with an increased risk of behavioral inhibition, and then behavioral inhibition is itself associated with 7 times the odds of later development of social anxiety disorder. So we've got the reactivity to behavioral inhibition to social anxiety disorder. There are parent anxiety disorders. Obviously, I've told you a good bit about those, summarising the meta-analysis we did. And we know from the earlier meta-analysis that parent anxiety disorders do seem to confer risk for offspring social anxiety disorder. And we know that social anxiety disorder runs in families, but what we don't know is whether the risk conferred by social anxiety disorder in parents is particular, or if it's general. Let me show you a diagram to help illustrate slightly complicated concepts, I think. So in order to work out the specificity of risks, we need very specially characterized groups. So we need a group of parents with social anxiety disorder but no generalized anxiety disorder, a group of parents with generalized anxiety disorder but no social anxiety disorder, and then a group of parents with no anxiety disorders. And we can then examine prevalence of social anxiety disorder in their offspring. And here's the pattern, like this, where social anxiety disorder is elevated in the offspring of parents regardless of the parent's anxiety disorder? Or is it that we see elevated social anxiety disorder in offspring only where parents had social anxiety disorder, but no different where parents had generalized anxiety disorder without social anxiety disorder? Also, parenting behaviors been very thoroughly implicated in certainly the maintenance and somewhat the development of anxiety disorders. And so we examined parental anxious modeling, over-involvement, and reduced encouragement as predictors of child's social anxiety disorder. So you'll see I've emboldened here that our research questions were about the prevalence of social anxiety disorder in childhood, as well as anxiety symptoms. And we thought these would be associated with stable temperamental inhibition in infancy, so in both early infancy and at the end of the first year, with maternal social anxiety disorder, but not generalized anxiety disorder, and where mums were observed to behave with more expressed anxiety and intrusiveness and less frequent encouragement. And also, we thought that these risks would interact such that A and B would interact, A and C would interact, and B and C would interact. So what we did, well, what others did long before I joined the project, was to screen 4,000 women at their routine check at 20 weeks during pregnancy, and were able to recruit, you'll see on the third line up, 67 mothers with social anxiety disorder, but not generalized, 56 mothers with generalized anxiety disorder, but not social anxiety disorder, and 94 control mothers without these disorders, plus some mums who had both, but they are not in these analyses that are about to follow. And then in the second wave of the study, when infants were about, on average, 58 months, we were able to follow up 53 of the mums with social anxiety disorder, 42 of the mums with generalized anxiety disorder, and 65 of the control mums. But none of those are the mums who had both social and generalized anxiety disorder. So we have those discrete categories as I showed earlier on. Temperament was assessed observationally at both 4 and 14 months following Jerome Kagan's procedures. Mother's parenting behaviours were observed at both 10 and 58 months, and child anxiety was assessed using the ADIS, the structured, semi-structured interview schedule for assessing anxiety disorders in children by asking children and parents, and the CBCL anxiety DSM subscale. And a schematic hopefully making this a bit clearer. You've got time running from left to right. So at 20 weeks during pregnancy, we've got assessment of maternal anxiety, including diagnostic assessment. 4 months postnatally, we've got child assessments begin. We've got reactivity. At 10 months, maternal behaviours were assessed. At 14 months, child BI was assessed. And then at 58 months, we've got assessment of child anxiety using the ADIS and the CBCL, and maternal behaviours and psychiatric status. We had to impute 30 data sets because of small bits of missing data, used logistic regression for diagnostic outcomes and fixed effects multi-level regression for the symptom-based outcomes, and had to standardize maternal parenting behaviors. And in terms of main effects, what we found was that at 58 months, child's social anxiety disorder was predicted by maternal social anxiety disorder in infancy, but not maternal generalized anxiety disorder in infancy. So that's exactly as we'd hypothesized. We found a very similar pattern for anxiety symptoms at 58 months with maternal social anxiety, but not maternal generalized anxiety predicting child symptoms at 58 months. And interestingly, again, too much detail for me to go into here, but at 58 months, so contemporary with the anxiety assessments, where we observed mum's behaviors in the lab with children, at 58 months, but not at 10 months, maternal intrusiveness predicted child anxiety, but only when we observed mums in contexts that were congruent with their own subtype of anxiety. So in a situation that was socially anxiety provoking, we found that if mums had social anxiety disorder, their intrusiveness in those situations predicted child anxiety, whereas that wasn't the case for mums with generalized anxiety. And in situations where they weren't socially anxiety provoking, but were generally anxiety provoking, that's where we found the relationship for the mums with the generalized anxiety disorder, but not for the social. Very interestingly, picking up on that question of whether the effects are additive or interactive, well, there were no significant interactions in predicting social anxiety disorder. In terms of child anxiety symptoms, whilst there had been no main effect of temperamental inhibition, we found that there was an interaction such that in infancy, so when we observed maternal encouragement at 10 months, where children showed stable temperamental inhibition between 4 and 14 months, they're the ones that in the with the blue dotted line on your screens, where they had stable temperamental inhibition. If mums were more encouraging, these children were less likely to be anxious at 58 months. If they were less encouraging at 10 months, these children were more likely to be anxious at 58 months. Whereas if they did not have stable temperamental inhibition at both 4 and 14 months, they were at no greater risk of anxiety, regardless of mum's behaviours. So what to make of these findings? Well, certainly the benefits of our design allowed us to demonstrate that specificity of risk for social anxiety disorder. Possibly it's too early to detect the risks from maternal generalized anxiety disorder, but we did see that the risks from maternal social anxiety disorder weren't only for the social anxiety disorder in offspring, but were also for offspring anxiety disorder symptoms more generally. Also, there was this, whilst there was no main effect of behavioral inhibition or temperamental stability of inhibition, it did interact with maternal behaviours early on. The limitations, well, we assessed temperament only very early, 4 and 14 months, didn't assess later in toddlerhood. We only examined mums, not dads. The sample was very affluent, white and well educated, took no account of genetic factors in the transmission of risk, and we have no treatment data, so we don't know what had happened in terms of mums receiving treatment between baseline and the first follow-up. But key points to take from this, and again, this is available, it should be, I think it's still open access online. Child social anxiety disorder and anxiety symptoms in childhood were associated specifically with social anxiety disorder in mums, but not with generalized anxiety disorder in mums. So it could be that child anxiety prevention could focus on modifiable risk factors in infancy, including social anxiety disorder in mums, and where children appear to have an inhibited temperament, maternal behaviours, including encouragement. Okay, so we've learned from study 2 that the risks are specific to maternal SAD. Study 3, we're moving on to prevention. So we want to know, well, does targeted prevention work, and what are people actually focusing on in their prevention studies? So is targeted prevention effective? Is targeted prevention effective? I'm pressing the wrong button, sorry. So what we knew, a couple of previous meta-analyses had examined this question, but they hadn't really asked the questions we were interested in, because what those meta-analyses had done was to include studies where children had been given prevention programs, but those children hadn't necessarily themselves been at risk of developing an anxiety disorder. They might have been recruited on the basis of a group level feature, such as living in a neighbourhood with a low SES, rather than being identified as individually at risk because of, for example, an inhibited temperament. Also in those meta-analyses, some children already had anxiety disorders at the beginning of the prevention programs, so they're not the ones whom we're interested in. Important that they get treatment, of course. We're interested in prevention of the onset of disorders. And also it was unclear whether participant or program factors moderated the effects of the prevention programs on children's anxiety. So just to pick up again on this issue of the multiple risks, independence of risks is unknown. We've got that they possibly interact from the study I just told you about, from Jennifer Hudson's study in Australia, suggesting that maternal behaviours early in childhood do interact with child inhibition in predicting risk of anxiety in early adolescence. And as from the Ashford study I reported earlier, there is that cumulative effect. So our research questions, forgive the noise, our research questions were, do prevention programs for children and young people who are individually identified at risk of developing anxiety lower the rates of onset of disorders? Do they also lower anxiety disorder symptom severity? And are the relationships moderated by participant or program factors? So again, we went from 3,000 studies down to 17 that met our inclusion criteria. No evidence of publication bias, study quality fairly good, except in the blinding, as often is the case for psychological therapy trials. Now, in terms of diagnostic outcomes, what we found, there were only 2 studies that reported diagnosis outcomes. And whilst they show effectiveness, sure, literally there is an effect, 2 studies is not something to be basing strong conclusions on. Symptoms, we had many more studies, and where they're compared to a waitlist control at the end of treatment or the end of prevention, the outcome favours prevention. You can see we've got a minus 0.43 standardised mean difference. But when prevention programs are compared to active controls, so fewer studies, you'll see that there's no significant difference between them. You'll see that the rhombus at the bottom is crossing that 0 line. So no significant difference between prevention and an active control. We have no follow-up data on active controls, but where they've had waitlist controls, follow-up between 3 and 6 months post-treatment, similar effect size to the end of treatment, and a slightly smaller effect size when follow-up conducted between 12 and 24 months. But again, that's based on only 3 studies, so not very strong, and also the confidence interval very nearly getting to 0. So what we know from that meta-analysis is that, well, there are just too few studies to assess for diagnosis. There are only 2. The effects of prevention, targeted anxiety prevention, are significant only when compared to waitlist controls, not to active controls. And that means we simply don't know whether symptoms have reduced because children and their families have participated in something / anything, or something specific, i.e. the very particular programs that they had, or it's some combination of both. We found that also effects were not moderated by child factors or program factors. What was really important is that of all these studies, children were very, very frequently, I think there were only 2 studies where it wasn't the case, children were most frequently identified on the basis of a single risk factor. So that means we're looking in this box where there is much lower risk possibly than where they've got more than a single risk factor. Similarly, the programs very, very frequently were based on CBT, and very commonly amongst those, the Friends program, and therefore the prevention programs rarely actually targeted the risk factors. Rather, they tended to be targeting factors that maintain anxiety rather than those factors that might lead to anxiety. So what we know about risk doesn't actually inform what people are doing to prevent anxiety. So in terms of what next, based on our results here, well, it's very important that targeted anxiety prevention is to identify children on the basis of risks at that individual level. Need to identify children in light of multiple risks rather than single risks. Got to focus on modifying risk factors, not just on modifying what might maintain a disorder, because they might not overlap perfectly. And also we need to be doing a much better job of assessing diagnostic status. Again, this is available open access online, so you can get far more information. So key finding there from study 3, programs simply don't target multiple risks, and I think that's a huge downfall. So then finally, barriers to access to targeted prevention. What we knew, well, very, very little. We knew very little about barriers to access to targeted prevention. We knew very little about how to implement targeted prevention. We do know that there are difficulties with targeted prevention of low rates of attendance at programs, little engagement with the programs, and possibly parents reporting that they themselves were anxious, unkeen, reluctant to attend group sessions. And a real problem with the literature to date is that we know about barriers to access to prevention only from those who have participated in trials. So if you think about that, it means we've only heard from families who have obtained some kind of access to targeted anxiety prevention. We've not heard at all from the families who haven't gained access. We know a bit from barriers to anxiety treatment, and these include parents saying they've had difficulties identifying anxiety as a problem. They've anticipated that professionals could dismiss their concerns, and that there's a very, of course, limited service provision. So these are the things that were informing us in wanting to ask families about what had been the barriers to access. And all the literature that there has been on prevention, barriers to prevention, key voices have been missing. We've heard from parents, but not at all from children and young people. And that's really important because they're crucial. And as children get older, they become much more involved in seeking and obtaining treatment. So our questions were, what do families, and this gets slightly complicated, but I'll explain it more on the next slide. What do families perceive to be the barriers to access to targeted anxiety prevention? And also, what characteristics of targeted anxiety prevention programs could help facilitate access? So you'll see I've got in brackets at the top there, what do families comprising adolescents who as infants were at risk of anxiety disorders and then themselves developed anxiety disorders, and their mums. That's my succinct way of trying to explain that what we had was a very, very special sample, because it's taken from that same sample I reported in the study of the specificity of risks for social anxiety disorder. So of those 246 families recruited at baseline, we had 34 whom we followed up in adolescence. So we know that these children were at risk for anxiety disorders in light of either maternal anxiety disorder and or behavioural inhibition in infancy. But for this particular study, what we said was, not only must infants have been at risk in infancy because of maternal anxiety and or behavioural inhibition, also they must have then gone on to develop an anxiety disorder. So we've got a participant pool here of 7 who were identified in infancy as at risk of anxiety, went on to develop anxiety disorder, but were never able to access gain access to a prevention program. Of these 7, 4 reported that they obtained treatment, but none obtained access to prevention. In terms of what we did in our methods, we consulted a PPI group as well as using the literature to develop our topic guide, and we used thematic analysis to analyse our data, and we found 3 key themes. which are really quite surprising. And I'll, again, just have to whiz through these, but obviously happy to take questions. So, very interestingly, and something I think we really hadn't anticipated, is about, it wasn't universally popular, the concept of preventing an anxiety disorder. So whereas one mum said, you know, you do whatever you need not to have problems develop. Sorry, I'm just going to move things on my screen so I can see the quotes. No, can't do that. Whereas other parents, for example, one mum said, well, part of me says, actually, there's a little voice saying, are you trying to create perfect human beings by preventing the development of anxiety? So not universally endorsed by parents. Not that we're looking for universality and qualitative study, but interesting. And similarly, an adolescent saying, well, I could have been put off if somebody else had said, maybe it's not the right thing to do. Also, they'd highlighted for us that there were possible negative consequences. So one mum saying, well, I'd feel concerned if the teachers were aware my child were at risk. So, you know, that child and that child, that they're going to treat them differently and they're going to get taught differently. And an adolescent had said to us that, well, I mean, it could have changed me as a person completely if I'd had an effective prevention program, and I don't know if I'd have wanted that. So there isn't this necessarily universal endorsement of anxiety prevention. In terms of when to intervene, well, adolescents told us that actually it certainly wasn't necessarily the case about getting in early. Perhaps it was more a case of waiting for symptoms to become a problem. And that was possibly because they might think, well, what's the point of doing this? Because it wasn't really a problem if you went too early before they became symptomatic. And whereas one adolescent, for example, said, well, yeah, maybe it could have been all right to have had it younger before anxiety was a problem. And a mum saying, yeah, I'd probably have waited for my child to have showed signs or symptoms. I wouldn't go straight away. I'd wait to see if there was a pattern. And that can link to something I mentioned earlier about identifying anxiety as a problem. Because mum said to us, for example, you know, you think you know your child, but you don't always spot the problems exactly because you're living with them day to day. And another mum said, well, she really struggled to identify anxiety as a problem, but would have actually quite liked something like a checklist to look out for, just like you would for any physical illness that somebody was at risk of. And another mum saying, well, you don't want to go to see the GP because you feel you're going to get slated, because normally when I go, they'll say, oh yeah, that's just normal. So didn't feel dismissed. So really similar to what we'd seen in the barriers to access to treatment. And when and whether to act in terms of responding to concerns about risk. One mum pointing out, well, there are a lot of kids who are really shy, but their parents just won't know. They have no clue how to support these introverted kids. So they really would have wanted some kind of early preventive support. Whereas another mum had concerns about responding to risk concerns, saying, you know, sometimes if you're pointing out the anxiety or this risk to children, you're actually making a problem worse. You're creating a problem. And another mum saying, well, actually, I'd be quite wary if somebody said, well, my child's at risk of developing an anxiety problem. Oh my goodness, what are they saying about them? So some quite mixed reports there. And in terms of what might actually help with addressing barriers to access, adolescents really keen on promoting awareness. It'd be a really good idea just to have a program that's known and talked about. People would know where to go, have someone to talk to. I think it's a really good idea. And a mum saying, I think perhaps if the school were to let them know, and this became really prominent, the importance of school, both in terms of promoting awareness and in terms of providing access to an anxiety prevention program. In terms of the practicalities, one mum was saying, well, it's probably a generational thing. You know, I'd probably far rather meet with somebody face to face than do anything online, whereas maybe that would be okay for my son or my daughter. And another mum recognizing the great opportunity provided by school because children spend so much time there, obviously at the moment, special circumstances. And also a mum recognizing that, well, certainly whilst she would have wanted to be involved in a prevention program, she wouldn't have thought it was necessary or even desirable, perhaps, for all the children to have to attend, the children who are at risk. So what what was really crucial from this study is that mothers and adolescents highlighted the important role for schools in promoting awareness and making programs available. And that's similar to the strategy that we see in targeted prevention of depression. We found that all mums wanted to be involved in anxiety prevention, but some adolescents said they would have been perfectly happy for only their parents, but not themselves to have been involved. And also, very interestingly, given how I was saying earlier, this is a unique group we've interviewed here, where they hadn't gained access. Amongst this group, barriers appeared to be slightly less tangible. So, for example, very real, stigma, for example, but less tangible than what we've heard about in those samples who gained access to prevention in trials, such as practical things like time commitments and travel difficulties. So the key to take from that very final thing is the key role for schools, and it's probably pretty important that we get tools to parents to be able to identify anxiety as a problem. And in terms of what next, well, very fortunate to have been able to obtain funding to be involved in 2 online anxiety prevention trials in the UK, one being led in Oxford by Kathy Creswell, and one being led in Sussex by Professor Sam Cartwright-Hatton. And I'll of course be very happy to come back and talk to you about those in 3 to 4 years when we know how that's gone. Okay, hopefully I've left adequate time for questions, and I believe that's the end.